Good afternoon to you all. My presentation is Hypertension to Heart Failure, an unpleasant journey. So, this is myself, and greetings from these two organizations to which I at present belong. So, I have no conflict of interest. So, as we all know, hypertension is the most common cause of heart failure after ischemic heart disease, and it accounts for 25% of heart failure cases. Risk of heart failure increases 2 to 3-fold in hypertension. SACF and ASA denominates hypertension as stage A and hypertension-induced left ventricular hypertrophy as stage B heart failure. All of us know it. In-hospital mortality in hypertensive heart failure is 2.4 to 10%. And surprisingly, among Asians, it is 13 to 15%. This hypertensive heart failure can be reversed by effective control of blood pressure. So, these are hypertension-mediated organ damage. When heart is involved, it leads to heart failure. Also, it is a risk factor for coronary artery disease as well as atrial fibrillation. Both the conditions precipitates heart failure. So, in the pathogenesis, it occurs directly because of increased pressure of afterload on the heart, leading to left ventricular hypertrophy, indirectly by neurohumoral activation. So, when there is neurohumoral activation, there is loss of regulation between pro-remodeling and anti-remodeling factors. There are so many factors. This leads to development of left ventricular hypertrophy. There is loss of coronary vasodilatory reserve, resulting in subendocardial ischemia. Myocardial hypertrophy leads to impaired diastolic relaxation, exertional dyspnea, and heart failure with preserved ejection fraction. Increased myocardial loss and fibrosis leads to heart failure with reduced ejection fraction. So, the journey does not occur directly. It is a break journey. So, it occurs in various stages. In degree 1, there is only left ventricular diastolic dysfunction. In degree 2, there is left ventricular dysfunction along with left ventricular hypertrophy. In degree 3, there is heart failure with preserved ejection fraction, and finally, there is heart failure with reduced ejection fraction. So here, the same thing, the features, clinical features of heart failure starts from degree 3. As you see, there is pulmonary congestion, dyspnea, and all other clinical manifestations. And in the final stage, there is dilatation of the left ventricle, resulting in all the features of chronic heart failure. So, left ventricular hypertrophy, there is concentric increase in left ventricular mass, RAS activation, growth factors, and cytokine release all leads to myocardial cell growth. Left ventricular hypertrophy with increased biomarkers, that is NT-proBNP and troponin. This identifies high-risk patients who are going to develop heart failure with reduced ejection fraction. And left ventricular hypertrophy becomes a risk factor for development of myocardial infarction. As we all know, hypertension is also a risk factor for coronary artery disease. Hypertension doubles the coronary disease risk. The shear stress of hypertension promotes atherosclerosis. Rupture of plaque may occur because of sudden rise in blood pressure, and myocardial infarction leads to acute as well as chronic heart failure. In arrhythmia, as already mentioned, is an important cause of atrial fibrillation, hypertension, which precipitates heart failure. So, this is the journey pathway. Hypertension increases raised level of angiotensin 2. It acts by angiotensin 1, leads to cell growth and fibrosis, which produces left ventricular hypertrophy. Also, there is increased noradrenaline and aldosterone and vascular remodeling, which increases blood pressure. And you see, blood pressure, raised blood pressure leads to more hypertension and is a vicious cycle. So hypertension begets hypertension if not controlled. Also, there is endothelial dysfunction as well as vascular inflammation leading to coronary atherosclerosis, myocardial infarction, which also acts as a cause for heart failure. Same thing, starting from hypertension, it leads to heart failure, and in between there is left ventricular hypertrophy, myocardial infarction, etc. So, in the signs, the pulse increases, may be irregular, blood pressure elevated, may be normal, may be reduced in later stage when heart failure develops, JBP usually raised, precordial examination, apex bit displaced, may be heaving, and lung base may reveal bilateral crackles, abdominal examination may reveal hepatomegaly. And in ECG, there is left ventricular hypertrophy pattern ECG with stent pattern T inversion. This is a patient with acute heart failure producing pulmonary congestion, and two-dimensional echocardiogram showing left ventricular hypertrophy, and pulse wave Doppler showing altered EA ratio. And a patient with hypertension developing inferior infarction resulting in myocardial infarction on the left side. On the right side, there is ventricular septal rupture because of left ventricular hypertrophy. So the treatment, lifestyle modification, pharmacological and device therapy. As we all know, lifestyle modification, most important thing is low salt and reducing weight. Along with that, other relaxation, meditation, regular exercise, heart healthy diet, etc. Pharmacological, all antihypertensive drugs lower blood pressure, but not all are equal to prevent heart failure. RAS inhibitors are effective to treat hypertension and to prevent heart failure. Chlorthalidone and indapamide are outstanding to prevent heart failure. Left ventricular hypertrophy, all drugs may prevent it, except vasodilators. Heart failure with preserved ejection fraction, ACE inhibitor, beta blocker, non-dihydropyridine calcium channel blocker, etc., and in later stage, ARNI. And when heart failure with reduced ejection fraction develops, diuretics in case of NOS class 2 to 4, and ARB and ACE inhibitor reduces morbidity and mortality. Beta blockers when there is compensated heart failure, and in patients who are still symptomatic, we should start ARNI. So these are goal of blood pressure. You see here, for primary prevention of hypertension, hypertensive heart failure, the ESC guidelines recommends less than 140/90, but 2017 ACC guideline, their goal is a bit lower, that is less than 130/80. But for secondary prevention, that is to prevent death and readmission of patients who already develop heart failure, the goal should be less than 130/80. But you see here, when heart failure develops, hypertension becomes a more problem rather than hypertension. So in device therapy, the usual indications like when there is LVB and ejection fraction less than 35 should go for ICD, CRT, etc. And the patients who are having multiple frequent hospitalization and who are in late stage of heart failure, they may need LVAD or they may be given the choice of heart transplantation. So the factors involved in development of heart failure in patients with hypertension are non-adherence to therapy, insufficient access to healthcare facilities, and clinical inertia, which mostly remains with the physicians. The lack of educational approach, diagnostic inertia, that is failure to consider diagnosis of heart failure in a subjects with raised blood pressure, and therapeutic failure to initiate a new drug, optimize the dose, or increase the dose when it is needed. So in conclusion, dear chairpersons, I want to mention that many hypertensive patients receive inappropriately low care. It is controlled in only 1/4 of patients who are on treatment. limitation of our healthcare system, economic constraints, non-adherence, and clinical inertia responsible. Significant number of those with uncontrolled hypertension go on to develop heart failure. Hypertension control is essential not only for primary prevention, but also for secondary prevention of heart failure. So, take-home message is heart failure. It is a failure of heart, not only heart. Failure of patient to control it, and failure of physician to control the blood pressure of his patient. Heart failure burden may be reduced to a great extent by optimum control of blood pressure. So these are references. So thank you all.
Thank you, Professor Prabir Kumar Das, for your time-demanding speech on hypertension to heart failure. Now I am requesting Dr. Habibullah Selim to say a few words regarding his presentation.
Thank you, Dr. Bijoy, and thank you IPDI for selecting me as a discussant. Actually, hypertension and our present journey to the heart failure is really one of the preventive approaches how we can prevent heart failure. And Dr. Professor Prabir Kumar Das has nicely explained and the key issues regarding these topics. I thank Dr. Prabir Kumar Das and also IPDI for arranging such a useful seminar. Thank you.